presentation is on perinatal stroke, which is an important topic for doctors and nurses who are involved in neonatology, because stroke is not that uncommon among neonates, especially when there is a tendency to get thrombosis. Neonatal, perinatal and neonatal strokes are very common. So it is important to have an updated knowledge regarding the neonatal stroke. Today's speaker is Dr. Sharmy Hassan. He worked as an acting consultant neonatologist in Sri Lanka, and currently he is in his overseas training and working as a neonatal registrar in Grant University Hospitals, Wales, United Kingdom. I think he will be able to give us an updated knowledge about the perinatal stroke from the experience that he gained from his overseas training as well. So I cordially invite Dr. Sharmy Hassan to proceed with his presentation.
Hello. Can you hear Kanchana?
Yes, we can hear you.
Clear?
You can share your slides. We can't see the slides.
Thank you very much, Kanchana, for the kind introduction. Can you see the slides now?
Yes, but it's not in the slideshow view.
Now?
Yeah, now we can see clearly. Okay.
So thank you very much for the kind introduction, and thank you for the Perinatal Society and Ceylon Association of Neonatologists to give this opportunity to present this presentation. So I'll straight away start the presentation now. So, okay. So the perinatal stroke, so as you mentioned, Kanchana, so it's not uncommon. So perinatal stroke, as a definition wise, if we take, so it's an acute neurological syndrome with chronic sequelae due to the cerebral injury of vascular origin. So it's tend to occur from 20 weeks of gestation to 28 days of postnatal life. So that cerebral injury can be either arterial ischemic stroke, or can be a cerebral venous thrombosis or intracerebral hemorrhage, which can result in acute neonatal encephalopathy, which will manifest as seizures, altered mental status, and sensory motor deficit, and also the chronic neurological disability. So this is the introduction they give. The definition is it's starting from 20 weeks of gestation to 28 days of postnatal life with involving cerebral vascular injury. So if we take the epidemiology, it's not rare. So it's after the adult stroke, it is the second commonest. It's approximately tenfold more than a childhood stroke. So there was a study done in Switzerland. They found to have it's 1 per 770 infant having this arterial ischemic stroke. So if we take if we take with etiology wise, the arterial ischemic strokes are the most commonest. So it accounts for 70%, and hemorrhagic strokes accounts for 20%, and cerebral venous sinus thrombosis is 10%. So classification. So again, with anatomical classifications with clinical anatomical subtypes, they call as. So can be classified as arterial ischemic stroke, so which conform to the vascular occlusion in a arterial territory. Then hemorrhagic stroke, so it can be either intracerebral, subarachnoid, or intraventricular hemorrhage. Other one is cerebral sinovenous thrombosis, which can be an infarction or hemorrhagic infarction. So it can be either way. Cerebral venous thrombosis, we'll discuss with that later, and periventricular venous infarction, that is most commonly occurring preterm babies, which associated with germinal matrix hemorrhage. So this is if we take some etiology wise, so this diagram represents so what are the etiological causes which causing this is arterial and this is venous. You can see some there are so many risk factors which are associated with these strokes. So we'll go one by one. So if we take arterial ischemia, so they say it's 3 types of main mechanism involving this arterial stroke. So it can be embolic, which can be a cardiac emboli or transcardiac or aortic origin, and anatomical disorders of cerebral arteries or thrombosis due to hemostasis. These are the three mechanisms mainly involving in arterial ischemic stroke. So you can see this arteriopathy, thrombosis, and embolism. So arteriopathies, it can associated with infection like meningitis. So degenerative disorders like fibromuscular dysplasias, meningitis, some rare causes, and malformations, and traumatic compression with this cervical compressions, which can cause resulting in this arteriopathies. And if we take the thrombosis, so it's mainly blood hemostasis. So genetic thrombophilias, as we know, the protein C, protein S, and antithrombin D3 deficiencies, and folate metabolism defect, and prothrombin mutation. So these are very rare, but still tend to occur. And also thrombosis can result in severe sepsis, DICs, hypovolemias, and ECMO also can cause some blood and which can end up in thrombosis. If we take the embolic wise, so the cardiac causes, congenital heart disease, heart failures, endocarditis, which can generate thrombus, and it can end up in embolism through PFOs. So these placental abnormalities sometimes can cause AI embolism, and which also cross through the PFO and can cause thromboembolic events. So if we take this water zone or watershed infarction, so the watershed areas, we know it's the area which is more vulnerable for hypoxic injuries because of less perfusion. So it's exists along the boundaries of major arterial territories in parasagittal region, which, as I mentioned, is a very prone area to ischemia. So if in the perinatal hypoxic ischemic events, these border zone area, the areas which affected first, as we discussed earlier, so these are the prothrombotic disorders which can result in thrombotic events. So protein C, S, antiphospholipid, factor V, and antithrombin 3. So these are rare but still there. You can see this CT and MRI films which was made in cerebral artery ischemic stroke. In this is a CT, and these are two MRIs which showing this this is a three-day old term pneumonic left-sided clonic seizure, and found to have this arterial ischemic stroke. So cerebral sinus thrombosis, it can be either venous infarction or hemorrhage. So in this picture, you can see this sagittal and as well as straight sinus thrombosis. This is the most common cause. It's like dehydration. We have seen this term babies coming with severe dehydration, and ultimately with the scan we find some thrombus. Then we move on to hemorrhagic stroke. So we earlier discussed with ischemic stroke. Now I move on to hemorrhagic stroke. So hemorrhagic stroke resulting from intracranial hemorrhage of non-traumatic origin. So two main forms. So one is a hemorrhagic conversion of ischemic infarction. So this is the commonest in neonates. So previous ischemic infarction can be converted into the hemorrhagic infarction. Or the other one is a primary intracerebral hemorrhage, most idiopathic, secondary, sometimes secondary to bleeding diastasis like thrombocytopenia, hemophilia, and other coagulopathies. So it's the primary intracerebral hemorrhage. And some other vascular anomalies, cavernous malformation, atriovenal malformation, aneurysm, and like veins of Gallen's malformation. So those are some vascular anomalies which can result after rupture of that malformation, can result in hemorrhagic stroke. So this is the severity of interventricular hemorrhage on cranial ultrasonography. So we know this grade 1, grade 2, grade 3, and grade 4. So grade 1 is germinal matrix hemorrhage, so which start from the podothalamic groove. So grade 2 is germinal matrix plus interventricular hemorrhage, but less than 50% of ventricular areas. The hemorrhage occupied less than 50% of the ventricular area. Grade 3 is interventricular hemorrhage involving more than 50%. Usually ventricles are distended. So grade 4, we know that is with parenchymal extension from the ventricles. So it's now called periventricular hemorrhagic infarction, this grade 4. So in this ultrasound pictures, we can see this is the grade 1 germinal matrix infarction in a preterm baby, 27-week-old baby. This is a bilateral infarct. So this is the starting point of this hemorrhage. So this is our coded. This is our thalamus. This is chordathalamic groove. So this is the starting for this germinal matrix infarct. So this is choroid plexus. Usually choroid start 1/3 of the thalamus. So the end you can see the the color. If you take this bleeding uh, color is different from this choroid plexus color, and this is the periventricular area. So this usually this in this periventricular area we tend to have this periventricular leukomalacia and cystic changes. So this is grade 2 germinal matrix hemorrhage. So it's in left side. So we can see in comparing with the right side, this is coronal view and this is the sagittal. So this is the hemorrhage and it's extending to the ventricles. So in the sagittal view also it started from germinal matrix and it's extended to the lateral ventricles. This is correct. This is grade 3 bilateral hemorrhage in a baby, in a preterm baby. So it's you can see this ventricles are lateral ventricles are grossly dilated and insufficient. In the sagittal also it's evident. So this is the grade 4 or the periventricular hemorrhagic infarction. Now they call, so it's extended to the parenchyma. You can see from this in this picture. And this is the MRI following the same baby. So it's evolved into a cystic lesion in the parenchyma. So periventricular hemorrhagic infarction, bit about it. So it's a part of spectrum of germinal matrix and interventricular hemorrhage. It's most common in premature infant. So they say the mechanism is obstruction of the medullary and terminal veins by the associated interventricular hemorrhage. It results in venous congestion, ischemia, and venous hemorrhagic infarction. So the infarction is asymmetric in contrast to PVL. So the periventricular hemorrhage and periventricular leukomalacia. So usually periventricular leukomalacia results from ischemic events. So this is hemorrhagic events. And because of this hemorrhagic event, it's most of the time asymmetric, but this PVL is a global event, so it's usually bilateral. So something about this periventricular leukomalacia. So it's a major form of brain white matter injury that affect premature babies mainly. So consists of periventricular focal necrosis and cyst formation. So this periventricular white matter area is vulnerable for ischemic insult. So usually we diagnose by ultrasound screening. In day 28 screening, we usually look for this periventricular leukomalacia with cystic changes. So in antenatal, we have to take a good history. If there's any hypoxic event from moms, any bleeding, PV bleedings. So which so usually in early days we cannot identify this periventricular leukomalacia. It will take some time to evolve. So usually there can be a periventricular brightness or flare, but it's really subjective. So clinical signs also very minimal. So sometimes they evolve into later spastic diplegia. So that's a common cause of periventricular leukomalacia, spastic diplegia (CP). Usually common in left side, usually bilateral, but common in left side. If and also the left side is worse than right side if it is occurring in both sides. So now we move on to clinical manifestation of strokes. So it's like a non-specific, like common neurological encephalopathic features. So encephalopathy, seizures, hypotonia, hemiparesis, focal neurological deficit, respiratory impairment, feeding problems, and some other asymmetry of spontaneous movements, exaggerated primitive reflexes, sensory deficit. So it's all depend on the uh, site and extent of the injury. So now move on to evaluation and diagnosis. So brain imaging is the first modality to come to a diagnosis. So MRI is the most sensitive for acute ischemic stroke and compare with other modalities. So we can detect within minutes if we can do an MRI. So usually they say that DWI, the diffusion weighted imaging, which detect very early. So that they say the mechanism behind that, there's a acute ischemia causing diffuse reduction in the water molecules in the brain parenchyma. So it will detected by this diffusion weighted imaging in early part of the stroke. So, but after 7 days, they advise to go T2 and flare MRI sequence, which more reliable than DWI, because the DWI after sometimes it cannot give uh, the extent of the infarction. So they say it's the extent and things for the most more extensive evaluation. So we better go with this T2 and flared after the initial period of stroke. So for the within few minutes or within few hours, the DW is the gold standard, they say, but after sometimes T2 and flare will be the investigation of choice. So cranial ultrasonography, if so most of the time we won't get MRIs as soon as we expect. So it's less useful in detecting ischemic strokes. You can see some flares and brightness periventricular, but it's very difficult to detect ischemic stroke. And sometimes your RI, so your resistance index will be less for the compensatory mechanism. So and the advantage of cranial ultrasound, it's readily accessible, non-invasive, fast, but we can identify hemorrhages from the ultrasonography. CT, if we they say it's inadequate, but if MRI is not available, we can go with CT and get an idea. Then the imaging, neurovascular imaging, so MRA and MRV, so this is mainly helpful in identifying the pathophysiology of stroke. So vascular anomalies, vascular malformation. So usually if there's a stroke, we tend to order this MRA and MRV in view of identifying the pathophysiology. And transcranial Doppler ultrasonography helpful in sinus venous thrombosis. Then, so the most common presentation of stroke, the seizures. So we have to evaluate the seizures. Why is this happening? So this is the most common presentation of stroke. So gold standard to evaluate the seizures, multi-channel video EEG monitoring. So we have to exclude the other causes of seizure also. So the initial presentation would be the seizures of postnatal babies might present with seizure. So we have to evaluate other causes of infection and other metabolic screening later. And we have to do an echocardiogram to detect structural heart disease with right to left shunting, because it can be a source of thrombi. And the coagulation screening, so especially the ischemic stroke, should be obtained only in highly selected cases. So they say usually to go if there's a strong family history of coagulation disorder, or there's a multiple site thrombosis other than and CNS, or in CNS also, if there's a multiple site infarction, we can do it, but there are so much limitation in this evaluation. So we can do maternal ANA, lupus anticoagulant, anticardiolipin antibodies, PTINR, APTT, protein C, antithrombin, homocysteine levels. And the limitation is, so the false positive and false negative rates are very high. So level of protein C, antithrombin, antifactor, usually they are less level in neonates, so 30% less, they say. So we have to repeat and see if even if it is positive. So management, when move into management, so general measures, so supportive measures are the main. So ensure adequate oxygenation and ventilation, correct dehydration, anemia if there is, correct metabolic disturbances, acidosis, hypoglycemia, hypocalcemia, electrolyte disturbance. If we are suspecting infection, to cover with antibiotics, and we have to treat the seizure. So anticonvulsion, we have to monitor with EEG. So if we move on, management of arterial ischemic stroke. So treatment with platelet agents or anticoagulants rarely indicated. So we in adults we tend to treat with antiplatelet and anticoagulation, but in neonates we don't treat, because most thrombotic strokes do not recur or progress in neonates. But neonates who have at risk of recurrent ischemic stroke, like thrombophilia and complex congenital heart disease, they advise to start antithrombotic therapy with aspirin and low molecular weight heparin. So in adults, we do thrombolysis and mechanical thrombectomy following a stroke, but in neonates, it's not feasible because of technically it's challenging and difficult to ascertain the exact time of stroke. So it can be intrauterine most of the time. So we can't predict when it has happened. Then cerebral synovial thrombosis management. So we have to, in case of synovial thrombosis, we have to start anticoagulation with unfractionated heparin or low molecular weight heparin. So it should be continued at least 6 weeks using low molecular weight heparin, and we have to do the repeat imaging to target the endpoint of therapy. Then management of intracerebral hemorrhage. So it's correct if there's a risk factors like low platelet and coagulation, we can correct that. And prophylactic vitamin K, and to do MRI and MRA to identify any malformation and like vein of Gallen malformation. In germinal metrics, so in preterm babies, it's mainly supportive and to preservation of cerebral function and like that. And after the infarct, hemorrhagic infarction, there can be a dilatation of the ventricle. So in that case, we have to do shunting for hydrocephalus. So it will take some time to develop this hydrocephalus. In that case, you have to go with this ventricular index and gestation. So they advise like this is the 97th centile of ventricular index. So if it is more than 4 millimeter above the 97th centile, so we have to do an intervention to remove the CSF. So either we can go for neurosurgical referral, or we can tap and remove, and we have to monitor this with serial ultrasound. And the other part of management is long-term rehabilitation, so physical, occupational, and speech therapy, and to improve the functional outcome and neurodevelopmental status, and innovative rehabilitative intervention with different modalities. There are so many new modalities available nowadays, and also the multidisciplinary long-term clinical care models and individual tailored intervention. Optimizing the integration of the child into home and school environment. So they modify the home and school environment to make sure that the child is having near normal life. So prognosis, it's wide variation because of the location and extent of the brain injury. So, and also the presence of comorbid medical problems also decide on this prognosis. Can cause long-term impairment in sensory and motor functions, including cerebral palsy and cognition, and also epilepsy and vision, hearing, and language behavior problems. So to summarize, perinatal stroke is a cerebrovascular event that occurs from 20 weeks of gestation to 28 days of postnatal life. So the major clinical subtypes: arterial ischemic stroke and hemorrhagic stroke, cerebral synovial thrombosis, and periventricular venous infarction. It's usually in preterm. Common clinical manifestation is kind of encephalopathies and seizures, hypotonia, focal neurological deficit, respiratory impairment, and feeding problems. So if in your evaluation, we have to do a brain imaging to define the lesion, and neurovascular laboratory investigation for underlying to identify the underlying causes. And management is mainly supportive, and most thrombotic stroke infants do not recur or progress like in adults. If risk of recurrence in arterial stroke and also the sinus venous thrombosis, then we treat with antithrombotic therapy. For neonates with intracerebral hemorrhage, so we can correct thrombocytopenia or any other risk factors, and we have to go with ventricular drainage and shunting for hydrocephalus. And perinatal stroke may cause long-term impairment in motor function, cognition, language, behavior, and mood, as well as vision, and can end up with epilepsy. So my reference. So, is there any questions?
Thank you very much, Dr. Hassan. your presentation, I think, will summarize the regarding the perinatal stroke, the etiology, how to evaluate, and the management. There is one question from Dr. Priyanka Demeter. Do we advise to evacuate IVH and ICH in acute state? And whether there's any difference of management in term and preterm babies?
No, at the moment we are not. So the one thing that I have discussed earlier. So we are not doing any thrombectomy or thrombolytic events in units till now, because they say the exact we are not sure most of the time when it has happened. It's sometimes it's happening intrauterine, even in if it has happened after the delivery also. So it's very technically feasible to access the these sites. And yeah, so the current recommendation is they are not recommending to evacuate this interventricular hemorrhage or ICH. And also in preterm babies, we most of the time we tend to know after this after the bleeding. So we do scans in day 1, day 3, and day 4. So they are not advising to remove the removal of the, so it's very technically challenging to removal of that. So, and they are not recommending also. So we closely monitor, and if there is a ventricular dilatation, so with that graph I showed, there's a fourth ventricular hemorrhagic dilatation. Then if it is above the 97 centile, they say the 4 millimeter above the 97 centile, to go with shunting and removing the CSF. So that's what they are saying.
Okay, thank you, Dr. Hassan. If you have any other questions, you can type in the Q&A or in the chat box.
Kanchana, can I comment something?
Yes,
Yeah.
sir. Yes.
Hassan, congratulations, and thank you very much for your very comprehensive presentation. Well done. That's a very good one. But I'm sorry, I joined the presentation about 15 minutes halfway through. But congratulations. That's a very good one. I think the answer to Priyanka, I think her question was about evacuation of IVH and ICH, right? That was a question. Am I right, Kanchana?
Yes, sir. Yes.
Yeah. In terms of evacuation of IVH or intraventricular intracerebral hemorrhages in newborns, normally it's not done. But there is a place for evacuation of extradural or subdural hemorrhages. If it is causing midline shifts, and if it is causing pressure effects, especially for extradural and mainly extradural and sometimes subdural, if it is causing some kind of midline shift, which can be life threatening. But for intraventricular hemorrhages and the intracerebral hemorrhages, for newborns, my knowledge, there's no place for evacuation because it can cause more damage. Definitely not for intraventricular. But there was one case where there was a large intracerebral hemorrhage with midline shift. I know of one case where the some kind of intervention done to release the pressure to minimize the pressure effect to midline shift, and that was done in one case, but that was successful, but that is not routinely done. I think we have very limited experience with that.
Thank you, sir.
Thank you, sir. If you have any other questions, you can type in the Q&A and chat box. At the moment, there are no any questions.
So I'll just present a case presentation of a pediatric stroke. So this is a pediatric case. So this is a 10-year-old girl presented with left-sided hemiparesis with left-sided upper motor neuron type facial nerve palsy. So her motor examination showed his power is low in left upper limb as well as left lower limb. So and also the cranial examination showed left side upper motor neuron type facial nerve palsy. So we thought of it's a cerebrovascular accident involving the right side of the brain above the facial nerve nucleus, above the pons. We know the facial nerve nucleus is above the pons. So we thought of right side internal capsular infarction. So we know that this is a neuroanatomy to some to to have a look. So this is the motor cortex, and this is our descending and ascending tract. So we thought of this infarction could be the higher up in the internal capsule. So this is the MRI which showed the multiple ischemic area involving the central semiovale and right internal capsule. Here you can see that lesions. So so in pediatric also it's not uncommon. That's what I want to say. And MRI was normally this girl presented at Badul when I was registered. So they say May is a childhood stroke awareness month. So
Yeah.
any other questions?
Hassan, I have a small message for the participants, mainly for the nursing staff. අපි හැමෝම දන්න එකක් තමයි මේ. Now the topic is strokes. Air embolism. Now people are worried about air embolism when you are අපි cannula එකකින් මොන හරි drug එකක් හරි එහෙම නැත්නම් infusion එකක් හරි මොන හරි දෙනකොට අපි පරිස්සම් වෙනවා මේ මම මේක ගොඩක්ම මේ දේ පැහැදිලි කරන්නේ අපේ nursing staff එකට. මොකද drugs දෙන්නේ IV දෙන්නේ IV fluids දෙන්නේ ඔක්කොම කරන්නේ nursing staff එකෙන් හන්ද අපි පරිස්සම් වෙනවානේ air embolism එකක් යන්නේ නැති වෙන්නේ air bubble එකක් යන්නේ නැති වෙන්නේ ඒ දේ කරන්න අපිට දැන් air embolism කිව්වහම මතක් වෙන්නේ venous එකකින් vein එකකින් යන air bubble එකක් vein එකෙන් ගිහිල්ලා heart එකට ගිහිල්ලා lungs වලට ගියාම pulmonary air embolism කියන එකට තමයි අපි ගොඩක් වෙලාවට බය. ඉතින් ලොකු වොලියුම් එකක් සැලකිය යුතු air bubble එකක් ගියොත් ඒක lungs වලට ගියොත් ඒ බබා එක සැරේටම bad වෙලා hypoxic වෙලා මැරෙන්න පුළුවන්. ලොකු ප්‍රමාණයක air ප්‍රමාණයක් ගියොත් මැරෙන්න පුළුවන්. එතකොට අපි ඒක තමයි අපි සාමාන්‍යයෙන් පරිස්සම්. නමුත් මේ strokes ගැන කතා කරනකොට especially newborns ට මම මතක් කරන්න කැමතියි nursing staff එකට චූටි air bubble එකක්වත් නොයන්න අපි වග බලා ගන්න ඕනේ. පුංචි air bubble එකක්. සමහර වෙලාවට පුංචි air bubble එකක් දැක්කම මම ward round එකේදී තෝන් තරම් සමහර වෙලාවට drips නවත්තලා තියෙනවා air bubbles මම ward round කරන වෙලාවට දැකපු වෙලාවට. අපි හැමෝම ඒ ගැන පරිස්සම් වෙන්න ඕන nursing staff එකයි medical staff එකයි හැමෝම චූටි air bubble එකක් හරි ගියොත් newborn බබෙක්ගේ අපි දන්නවා හැම newborn කෙනෙක්ගෙම patent foramen ovale කියලා තත්වයක් තියෙනවා. කියන්නේ heart එකේ උඩ කර්ණිකා දෙක අතර තියෙන බිත්තියේ යම්කිසි ඕපනින් එකක් තියෙන ඉපදිච්ච ගම. එතකොට පුංචි air bubble එකක් ගියත් ඒක දකුණු පැත්තට ගියාට ඒ patent foramen ovale එකෙන් ඒක දකුණු පැත්තෙන් වම් පැත්තට යන්න පුළුවන්. ඒ air bubble එක වම් පැත්තට ගියොත් ඒ වම් පැත්තට ගිය air bubble එක තුෙන් යන්න පුළුවන් heart එකේ වම් පැත්ත හරහා ඒ කියන්නේ අපි දන්නවා මහා ධමනිය හරහා එහෙම නැත්නම් මොලේට යන්න පුළුවන් එහෙම නැත්නම් peripheral limb එකකට යන්න පුළුවන් කොහාට හරි peripheral arterial supply එකට යන්න පුළුවන් එහෙම ගියොත් එතනින් එහාට infarction එකක් වෙනවා එතකොට ඒක අපි හැමෝම මතක තියාගන්න ඕන දෙයක් හැමෝම පරිස්සම් වෙන්න ඕන දෙයක් පුංචි air bubble එකක් මේක සාමාන්‍යයෙන් pediatric patient කෙනෙකුට එහෙම නැත්නම් adult patient කෙනෙකුට පුංචි air bubble එකක් යන එක ප්‍රශ්නයක් වෙන්නේ නැහැ මොකද එහෙම තත්වයක් ඒගොල්ලන්ගේ නැති හන්ද එතකොට newborn කෙනෙක්ගේ heart එකේ වම් පැත්තේ දකුණු පැත්තේ අතර සම්බන්ධතාවයක් තියෙනවා ඉපදිච්ච ගමන් ඒ වම් පැත්ත දකුණු පැත්තට එන air bubble එක වම් පැත්තට යන්න පුළුවන් වම් පැත්තට ගියොත් ඒක මොලේට යන්න පුළුවන් මොලේට ගියොත් අනිවාර්යයෙන්ම stroke එකක් එන්න පුළුවන් ඒක ඒ විදිහටම වෙන්න පුළුවන් ASD එකක් තියෙන දරුවෙක්ගේ එහෙම නැත්නම් ASD එකක් තියෙන adult කෙනෙකුට ඒ තත්ත්වෙ එන්න පුළුවන් ඒක හන්ද මම මතක් කරනවා හැමෝටම අපි IV drugs දෙනකොට infusion සම්බන්ධ කරනකොට පුංචි air bubble එකක්වත් යන්නේ නැති වෙන්න අපි ඒ දේ කරන්න වග බලා ගන්න කියලා මම මතක් කරන්න කැමතියි මොකද ඒක life saving ඒක හරිම dangerous එහෙම වුණොත් ඒකෙන් stroke එකක් එන්න පුළුවන් මේ අපි මේ Dr. Hassan දැන් පැහැදිලි කරපු විදිහේ thank you
Thank you very much, sir. I think it's a very valuable information to all of us. I think there are no more questions, so we can wind up the session. I would like to thank Dr. Hassan for allocating his valuable time to enlighten us regarding the perinatal strokes, and also our sir, Dr. Saman Kumara, for participating and giving your valuable opinion to us as always. And also all the attendees who have participated for the lecture, because the current situation is very stressful to everyone because of this school crisis and everything. So I would like to thank all of you for joining for today's presentation as well. Good night, everyone.
Thank you, everybody. Thank you. Good night. Bye.
So